the ATE management of any unwell patient will serve you from the time you graduate until the time that you retire. You'll never stop doing this, and I think anyone that you find that's unwell, whether it's on a ward or an A&E or on the pavement, you know, you can always fall back on this. So I'm just going to take a moment to kind of go through this with you, and I've got another slide here which is even I've stolen from a website. It looks like a Danish website, and I think it's a really good slide to just pick out all of the parts. So when you approach the patient, you look at them from the end of the bed, you have a listen. Are they talking? Are they speaking to you? Are they breathing? Always checking to see the patient's awake and breathing is a good thing. If they're not awake, not breathing, their heart's not beating, it's maybe a different scenario from a deteriorating patient. You're already looking at a patient who has deteriorated and arrested. That's a completely different story. But for the sake of talk, we'll say the patient isn't quite arrested yet, and we'll say you've got a patient in front of you. Their eyes are open. They're talking to you, but they sound a wee bit wheezy. And you would say, well, okay, their airway's probably intact. They're not stridulous. They're not coughing, and they're not a trauma patient, so they've not got any C-spine issues. In that instance, you'd be able to move on. Breathing, well, you know, they sound a bit wheezy. They're not really speaking in full sentences. You've got a full assessment you can do there. You can listen to their chest. You then start measuring their vital signs. Those sorts of things that were on the news chart are still part of our ATE assessment. Measuring the respiratory rate, you find their SATs are 95% on air. The respiratory rate's 26. At this point, well, you're maybe not going to need to, their chest sounds wheezy, but it's clear there's not any loss of air entry. At this point, you maybe want to start doing things like ABGs, chest x-rays. If you were to go further forward from there, you know that there's a respiratory rate that's high, but there's no saturations to correct. You find that they're cardiovascularly stable, their capillary refill time's less than 2, heart rate's 80, blood pressure is 130/80, and they're not actively bleeding at all, and they look warm, still huffing and puffing away. You'll probably still want to get IV access, blood sent away, fluids maybe not immediately important. 12-lead ECG, every unwell patient should probably have one. Every patient who comes into hospital should have one, and we could talk about ECGs a wee bit later on. Urinary catheter, probably not indicated. And again, echo, fast scans. Point of care ultrasound, while it's becoming more and more used, and it's something that I'm trying to learn how to do this year, actually it's still very user dependent, and it's probably not something you're going to be doing until you're a wee bit more senior. You move forward to the D section and you would check to see what their GCS is or whether they're alert. And in this case, the patient's GCS 15, pupils are echo and reactive. And there's not really much to do from that point of view, apart from check glucose, which I actually can't see on this sheet anyway. Oh, there it is, blood glucose. So yeah, blood glucose, never forget it. And then exposure is essentially just looking head to toe in the patient, looking for any wounds, fractures, trauma, have a feel of their tummy. Is it sore? Is it soft? And at that point, you might do any cultures from any wounds you find. Blood cultures would probably get done when you were putting a cannula in and taking blood from them. So that is just a general ATE assessment. I'm sure the more senior students among you and junior doctors will have used that 1,000 times. They'll have heard that 1,000 times and they'll have documented it 1,000 times. But I still think it's really important to just go through the whole thing every once in a while, and especially when I'm talking about a critically unwell patient, it's important to think about that.